Hello, everyone. My name is Katie Granacci. I'm the relatively new program evaluation specialist for MEDIC, and I am super excited to be here and help moderate this panelist presentations. We've had the discussion. You know, QI is really a team effort. We understand that for a lot of our sites, and here we're going to highlight a little bit about the abstractors. They're really the driving force sometimes behind a lot of the QI work. And so they're going to talk a little bit about their work that they do for their providers and kind of how they work as a team, and a little bit about their QI journeys that Megan was mentioning just previously. So please feel free to drop some questions in the Q&A feature on the Zoom. We are hoping for this to be a little bit interactive. We're hoping to hold most questions towards the end, but if anything comes up specific to one of the abstractors presentations, we're happy to bring that up intermittently as well. So first, we are going to start with Heather Ferrone. She is the abstractor from Henry Ford, Detroit. Just a couple little things about them. So they're one of our mixed population sites. They've joined MEDIC in the beginning in 2016. They see over 100,000 patients annually, and they have just over 70 providers. So welcome, Heather. Take it away.
Good morning, everybody. I'm excited to share with you how we send out our MEDIC data and performance to our providers. This data gets sent out about every 3 to 6 months, and it's for both our CT head injury and CT PE. But for this example here, I'm going to primarily focus on head injury data. I put together a MEDIC data email packet, which includes an opening letter and a single PDF attachment. The opening letter in the email provides updates on our MEDIC performance, current progress, areas for improvement, and ways to increase our success. The single PDF attachment contains various pages of MEDIC data and references, which includes an individual performance table and graph, a trend graph showing facility performance of appropriate head injury CT scans, a ranking chart showing facility data compared to other MEDIC sites, clinical decision rules for the initiative. Also, depending on how the data looks, additional tailored resources and various MEDIC tools are used. And in order to keep the data organized in the attachment, I'll start by putting all the CT head injury data first and any tools I use with that, and then I'll finish it off with the CT PE data last. So as we move to the next slide, you can see an example of our de-identified provider performance table. To help keep things simple, this is just a sample of our ED providers. Providers receive a separate email which contains their de-identified code to self-identify. This table details individualized data and feedback, which includes CT scan appropriateness. I also include the numerator and denominator and the clinical calculator use that they document in their notes. That's something separate that I keep track of. After I retrieve the data and organize it in this table, I then filter the appropriateness percentage from the lowest performer to the highest performer. I shade the lowest 25% performers are shaded in gray. I use bright bold colors to highlight the MEDIC average, the P for P goal, and the hospital average, just so they can have some comparison so they can see the difference. As we move to the next slide, this bar graph will show the CT scan appropriateness for all individual providers. The same provider codes are listed at the bottom, and providers are divided into 3 groups. So you have your low liars that perform less than 25% of their peers, providers that perform less than the MEDIC goal, and then ones that are greater than the MEDIC goal. And then I use the brightly colored colors as well, just to kind of make it stand out a little bit more. The next slide contains a sample letter that are sent to physicians that fall into the low 25% group for CT appropriateness, which are the same ones listed on the previous table that were shaded in gray. I have a separate letter for each cohort, so one for minor head injury and one for the CTPE cohort. I start off by introducing myself, give a very brief MEDIC overview, and let them know this email is a notification only and no response is required, but encourage to reach out if they have any questions. I also attach an Excel file of all their cases with the most recent 10 cases having feedback included for their review. This graph here represents the overall big picture and view of our progress. This shows our hospital overall CT appropriateness compared to the MEDIC average. appropriateness is in the blue line and the MEDIC is in the orange. I also include CT head utilization, which is the green line and includes the trend line. This is another way to show how there's been a reduction in CAT scans ordered overall. As you can see in the graph, there has been an overall decrease in the number of inappropriate CAT scans as the appropriateness increases. I keep a separate table and calculate the CT head utilization on my own, and then I plug the numbers in to create this graph. So overall, there's a decrease in the amount of CTs being done. Next slide, please. This is our evidence-based algorithms for head injury and PE that also gets included in the attachment that we sent out. This helps reinforce and provide education. Something else I also include, but it's not listed here, is a rankings chart showing our performance compared to all other MEDIC sites. And I think eventually, even though we can't get it now in Tableau, but eventually this will be available. So the ranking graph is nice to show because it gives a broader view as to how we stand and compare to other sites. So as we move to the next slide, this is my REDCap review email. We recently started this probably in the last 6 or 8 months. After the monthly cases are abstracted, I put together the most recent single month of data performance for review for our head injury cases with all appropriate cases attached in an Excel file. Sorry, inappropriate cases attached in an Excel file. Depending on what this data shows, I may send out additional tailored portions of maybe the monthly report like you see here, a portion of that or a portion of the scorecard or overall data performance, just to kind of keep everybody on track. This email is sent to our quality leadership, clinical champions, and residents helping with MEDIC and provides the detailed feedback about fallout and appropriate CT scans, which goes through our departmental quality assurance process. Case reviews are completed by Dr. Slezak and a resident, then emails are sent to providers for case review and to comment on CT indication. This generates a signal to providers to let them know they are being reviewed and that this is very important. This overall has been showing us great results. Since we joined MEDIC, we've seen a steady increase in CT scan appropriateness and a decrease in CT head utilization since joining MEDIC in 2016. But there has been a significant increase in CT appropriateness since starting this REDCap review. So I think this last part here is what has really helped us and kind of seeing some accountability with it. So that's it.
Thank you so much, Heather. Megan, do we have any questions for Heather? Nope. Okay. So we will move on to Kristen Watson. So she is the abstractor from our DMC Children's Hospital of Michigan site. They're obviously a pediatric only institution. They see somewhere between 75 and 95,000 visits annually. She has between 55 and 75 ED providers, and they joined MEDIC in the beginning as well in 2016. So welcome, Kristen. Take it away.
Hi, everyone. I'm Kristen. Raj Arora is our clinical champion. He is amazing, very interactive with all the work that we do. Nancy Radovic is my counterpart and our second abstractor for CHM, and Deb Nibala is our administrator. I wanted to make sure I mention all of them because this truly is a team effort. We each bring a little something different to the table as we work on, driving change. So like Katie mentioned, CHM began with MEDIC in 2016. In the beginning, our focus was just to introduce MEDIC to our providers, spread awareness. Raj did a lot of this through meetings. And then as we were spreading awareness, we were kind of developing, we started abstracting in June or July of 2016. And that was kind of determining our baseline data. And from there, we developed some posters just to kind of further spread awareness of PCARN and chest x-ray ordering guidelines. We hung those posters throughout all of our EDs at both Troy and our main campus. Our providers tend to go back and forth between both sites. Once reporting became available, we kind of dove into reporting, kind of seeing where our baseline was, looking for areas where we could really improve. And through that, we developed some quarterly performance reports. And those were both at the site level and at the provider level. And I also think it's important to note that at that time, these were just our basic Excel reports, very basic, and they were blinded. So I would create the reports, share them with Raj, and then there would be like one-on-one communication with providers on an individual basis. After like going forward, we started some internal tracking, mainly with the head CT utilization for overuse and intermediate. We have 2 separate spreadsheets that we use to track these. We track every single one. And this has really helped us identify areas for improvement within those measures. Unfortunately, we haven't been able to institute that for chest X-ray utilization. There are just way too many chest X-rays to go back and track, but it has been very helpful with the head CT utilization. Fast forward to present day for 2021, our focus is really on provider engagement. We have created some visuals and increased our performance reporting more frequent levels. We're sharing it with our providers more often. So you can go ahead and go to the next slide. The provider engagement is what I really want to kind of focus on today. This is kind of what we're working on this year. What you can see here on this slide is an example of our color zone chart. This one is for head CT utilization for the intermediate risk group. We have a green zone, a yellow zone, and a red zone. Ideally, we'd like everybody to fall within the green zone. We've also created a similar chart to this for chest X-ray utilization, and that will include asthma, bronchiolitis, and croup. We've also done a third version, which just includes the utilization of chest X-ray use in our croup patients. Typically, what we're seeing here is we usually have 2 columns of providers falling within the green zone, 2 columns of providers falling within the yellow zone, and kind of 1 column, just a couple names here and there, falling within the red zone. We'd like to get our providers that are in the red zone to move to the yellow zone, get some of our providers in the yellow zone to move to the green zone to kind of drive change and increase our, help us meet those metrics. So we've only been able to send out 1 version of each of these 3 color zone charts so far with the switchover of the database and Tableau. But our goal is to send the chest X-ray utilization versions out on a quarterly basis, so every 3 months. And the head injury, the head CT utilization, we'd like to send that out probably every 5 to 6 months, only because with the lower level of data, it might not show as meaningful use if we send it out, a meaningful change if we send it out more frequently than that. I'd like to note that this is our first attempt, I think, at kind of unblinding the data. So all the providers can see everyone's names and where they're falling in the color zones here. The way that we send this out is I kind of pull the data, create the chart, I send it on to Raj, and we include this as an attachment, as well as in the body of the email. That way, providers won't have to click on that attachment to see it. It'll be right there. Hopefully that will kind of encourage our providers to take a closer look at it and kind of see where they're falling. You can go ahead and go to the next slide. Oh, can you go back 1? There we go. Okay, so another way that we've decided to kind of visually engage our providers with measures and CHM's performance overall is through a performance scorecard. And this is an example of the first version that we sent out. This went out in February. We have the MEDIC target, P4P targets there. Then our numbers would be populated here based on, what I pull from Tableau. And green, obviously green is good. So that means we're meeting the target, we're doing good. Red, obviously we have a little bit of work to do and we'd like to see some improvement there. We send this out monthly. I complete it after, our abstraction for that given month is completed. And we, again, we send this as an attachment via email we send this via email, a provider group email, and it is included as an attachment as well as a screenshot within the body of the email so that people don't necessarily have to open that attachment. And then you can go on and go to the next slide. So I thought it would be good to share kind of our first 3 versions because we've made some changes as, you know, each version has been created. We're really trying to engage our providers, get them to kind of see where we're falling with these targets, stay on track. So we thought maybe changing the background so it looks like something that they haven't seen before would be beneficial. So each month we change the background. Obviously you get new data. We've added a header to kind of show a data reference range as well as a trend column to kind of show the change from the previous report. So whether we're is the data being, you know, are we increasing from last month? Are we decreasing from last month? And you can go ahead and go to the next slide. So this is the 3rd version. This one went out in May. One thing that I didn't mention on the previous slides, we have these blue boxes here, and we really try to highlight an area of focus based on what we're seeing with the abstraction and the data. You know, how do we stay green? How do we get to green? We'll kind of include, you know, a little tip or a tidbit, something, an area of focus to kind of, you know, help keep these ideas fresh in our providers' minds. Over the past 3 to 4 years, we've already noticed an increase in engagement and awareness. And I know Nancy and I can both speak to that based on what we see on abstraction. We've seen, you know, way more providers referencing PCARN in their medical decision-making. We see, you know, more detailed asthma reassessments. So we definitely see the engagement. It seems like our providers are aware. And what we're hoping with these visuals and increasing the frequency is that we can just really keep these measures on the top of our providers' minds and hopefully see, you know, meet the measures a little more than what we currently are. But thank you for letting me share all this with everyone. And if anybody has any questions, I'd be happy to try to answer those.
All righty. Thank you so much, Kristen. Megan, do we have any questions? All righty. So we will move on next to Nancy Wu. She is one of the abstractors for St. Joe Mercy Health in Ann Arbor. They are also a mixed population site who sees between 75 and 100,000 patients annually. She has between 75 and 99 ED providers, and they joined MEDIC close to the beginning as well in 2017. So Nancy, whenever you're ready.
Well, good morning, everybody. I'm sharing a little bit of a different story. I'm talking about the growth and development of an abstractor and where our facility currently stands with data management. My incredible champion, Dr. Lee Benjamin, is an emergency department pediatric physician, so I thought it fitting to use a growth and development theme today. To put this in perspective, now I feel like I'm copying what Megan talked about a little bit, but I'm the newest MEDIC abstractor of today's presenters. My colleague panelists have been in their roles from 8 months to nearly 2 years longer than I have. So I'm the newest abstractor in this presenting group today. I'm going to talk a little bit about my first year or my infancy with MEDIC. I had to find my way around. The collaborative concept was new to me. Blue Cross Blue Shield affiliation was new. What were the goals of this project and what's the potential impact of my hospital? I had to learn all of those pieces. I also had to learn about each cohort. As an abstractor, that's our work. What was the science and the current practice behind each one of these cohorts? I read lots of the MEDIC provided articles. I also needed to learn about the database and each data element. It's key to our abstractor work. Initially, I had many questions about all the data elements, and I still have questions today. So I'm going to point out here that MEDIC has also grown over the years. All abstractors know that we now meet monthly to discuss the nuances of the data elements in our data dictionary. Katie and Carrie teach us, and they strive for consistency across all of our facilities with the goal of integrated reliability. I also had to learn about the reporting tools available to us. What are these reports telling me? How do I apply this data to our practice? And in a way, I feel like we're kind of relearning the reporting now with the transition to Arbor Research and Tableau. On the next slide, I'm going to talk about managing data. So when I was a youngster with MEDIC, I started looking at the monthly performance. I was building data as I abstracted cases, and after several months, I could see our facility friends. As a medic toddler, I learned how to extract Excel reports, and I could see more information. It was a deeper dive into our performance. But again, what do I do with all this information? One thing I identified early on, though, is what I felt was a gap in reporting. I wasn't seeing all of our clinicians. The attending physicians were present, but there were no physician assistants or nurse practitioners. In a prior job, after I would share results with clinicians, if they'd run across one or two cases where their orders weren't their own, I'd hear comments like, well, this isn't my data. You can't critique me on this. Or this data isn't valid. I can't trust these numbers. So I really, really wanted to avoid those concerns regarding this new MEDIC project. I'm really fortunate to work with a supportive team. MEDIC launched at St. Joe's Ann Arbor and Livingston simultaneously. Paulette Haroff is the phenomenal Livingston abstractor who also abstracts Ann Arbor cases with me. So to stay in sync, we talk routinely and also discuss items before we bring them to our champions. Again, Dr. Benjamin in Ann Arbor and Dr. Seeloff in Livingston. We all collectively had conversations about provider-specific data, and our team felt strongly we needed to capture individual clinician data. So our process, early on in abstraction, Paulette and I began recording the ordering clinician in Abstractor notes. So why would we take this extra step? Because we know that many cases have a change of shift handoff, and also physician assistants and nurse practitioners work with a myriad of attendings in 1 month. By blending their orders with attending physician orders, we're losing what their contribution is to practice as it's diffused among so many attendings. And by identifying individual clinicians, this allows us to share provider-focused feedback. So about this time, I was sharing really simple Excel graphs with my champion. And for the most part, I was doing some manual calculation to come up with individual clinician performance. In January of 2020, Trinity Health in Michigan decided to made the transition to Epic. Shortly thereafter, we all felt the COVID pandemic. Despite those challenges, later in 2020, Paulette and I were fortunate to work with a St. Joe expert to learn about pivot table construction. As a result, we're now able to provide pivot table reports to our champions. On the next slide, you're going to see just a section of the adult head injury graph I can now share with Dr. Benjamin, and I'm sharing this quarterly. There's probably 10 more clinicians off to the right, but I wanted you to be able to actually see this a little bit. So what you see here is the green part of the bar, if you can't read it, is the number of appropriate scans for that clinician. The reddish-orange part of the bar is the number of inappropriate scans. And on the gray line, if you can see that, indicates the percentage of appropriate scans. I've obviously eliminated provider names at the bottom so that I could illustrate this without breaching confidentiality. So looking at this graph, you can see how clinicians line up with their colleagues. Anybody can look at this and see where they stand. And the graph includes performance of all of our clinicians, attending physicians, nurse practitioners, and physician assistants. So at this point in time, we're not sharing this report unblinded with clinicians. The timing just isn't right. There's work to do, but eventually we'll get there. And as Kristen mentioned, we also use the provider-to-provider communication process. So Dr. Benjamin uses this information and he reaches out to the clinicians to coach them about best practice. I'm not a physician. I don't have the same clinical expertise or medical framework. So he's excellent at that component. So in conclusion, now as an almost 4-year-old MEDIC abstractor or preschooler, I found that there's constant growth and development opportunities, also known as continuous improvement, even for abstractors. From my perspective, this work is constantly evolving. I love hearing about all these other processes because we can learn, we can continue to grow and apply data management practices in our respective environments. So thanks for listening to my story.
Thank you so much, Nancy. Megan, any questions here? Nope. Okay, so we'll move on to our last, but certainly not least, Abstractor presenter. It's Andrea Millard. She is the Abstractor for our Mid-Michigan Medical Center up in Midland, Michigan. They're also a mixed population site who see 40 to 45,000 patients annually, and she has 15 to 24 ED providers rotating, and they joined MEDIC also in the beginning back in 2016. So Andrea, whenever you're ready, go for it.
Good morning. The coordinating center asked me to share some of the interventions that we've been working on since we started our journey with MEDIC. The next slide, please. The first column normally would have our providers' names, which obviously I took out for this. The first two columns that show you the data, those are showing you our appropriate number of scans over the total number of scans that we did. For the first column is for the adult head injury. The second column is for the pediatric head injury. The third and fourth column are just showing you the number of diagnostic tests ordered over the total number of patients that fit in that cohort, whether it was for the pediatric chest x-ray or for the intermediate use head CT. It's kind of a confusing thing. If anyone has questions on this later, I'd be more than happy to help answer those. The next slide, please. When we first started trying to figure out how we were going to address the intermediate pediatric head injury cases, we really didn't know what to do. I ended up reaching out to the coordinating center, and she met with our team. And Dr. Nypaver actually suggested to us that if we encouraged our providers to observe only the patients that had one of the symptoms listed over on the left side of the screen under observation, whether it was nausea, LOC, or severe headache, those ones with only one symptom should be observed, versus the ones that had more than one symptom would be more likely to be the ones receiving a head CT. I did dive back into data from November to August, and I looked, and if we had followed Dr. Nypaver's suggestions, then we would have been well below the target goal of 18%. We would have been at 11%. We provided this information to our clinical champion, Dr. Swaya, who's on this, and also our medical director, and they did share this with our providers. And I've only recently in this last month started giving the providers some feedback on those intermediate head injury cases to let them know how many criteria the patients they scanned had. So we can keep monitoring that very closely and see if we can make a big difference this year. Next slide, please. When I first started abstracting the PE cases, I found there were so many of them coming to us with a positive D-dimer from our local urgent cares. They were coming here expecting to have their CTAs done. I felt this put our providers in a pretty bad spot because a lot of the decision-making was already taken out of their hands by them coming in with this positive D-dimer. So I reached out to the urgent care medical director and the office manager. They came over here. They were happy to meet with us. And it was really surprising during that meeting that the medical director for the urgent care had no idea that her providers were ordering so many D-dimers. She felt this wasn't a test that was appropriate to do in the urgent care setting, so she didn't think that was even something they needed to discuss. Well, shortly after that meeting, she went back and talked to her providers about this. And honestly, it's been 2 years since we had that meeting, and I've probably only seen a handful of these cases come back through our ER. So it really was a successful step. We also used that time to talk with them about how sometimes they may unintentionally set patient expectations of the ones that they're sending over to us when they tell the patient or the family the emergency department might order the following tests. The patients seem to be hearing it as the emergency department will order these tests and often think that they should be ordered as soon as they arrive in our triage area, which when it doesn't happen, it leads to decreased patient satisfaction. We had gotten copies of the Choosing Wisely campaign posters and badge cards, and we shared those with the urgent care also. As we have those posted out in our waiting room, we thought that they could maybe post them in their waiting room also. And this was just another step on setting those expectations so that when they were getting the kids or the adults coming in there with a head injury, they were sending them over to us for further evaluation. They weren't setting that expectation that, of course, you're going to have a CT when you arrive to the ER. So that has definitely been helping us also. The next slide, please. I reached out to our lab director to find out if we could switch to using age-adjusted D-dimers after noticing in our charting that a lot of our physicians were calculating those on their own. Our lab director wasn't very familiar, and when she reached out to one of her contacts at actually one of the other MEDIC sites that isn't using it, she wasn't really sure where to go after that to get more information. So I was able to reach out, and big, huge thank you to Heather from Henry Ford and Nancy from St. Joe's Ann Arbor. They provided with me a copy of what their lab reporting tool looks like so that I could share that with our lab optimization team to see if that's something that we can be moving towards getting for our facility. I'm very hopeful we will. I'm still waiting to hear back though. When we found out that we were going to be having a bigger focus on the safe discharge for the low risk chest pain patients, we were a little nervous about how high the number was set, and we're worried that maybe it wasn't going to be easy to achieve. I did end up going back. I'm a big Excel person, so I had all this data in an Excel sheet already. I looked back through these cases and looked to see what the disposition was for each provider, whether they were sending the patient to OBS, if they were sending them over to our chest pain clinic, or whether they were going to their PCP, and also looking at to compare it to their heart score. When I looked through that and dove into it a little bit more, I was able to identify some outliers. Those I did give to our medical director so that he could go back and speak with those to see if by possibly altering the practice a little of one or two providers, if we could make a big difference for our site. And I'm glad to say that our numbers are looking really well right now. If anyone has any further questions, let me know.
All righty. Thank you so much, Andrea. So I want to thank all of our abstractors for their presentations. And at this point, we'd love to open it up to some questions from the audience. If anybody has anything. Okay.
Yep. So we have one question from a new site that just joined this month, and they are thinking ahead to the new wave of residents who will be coming next month. And I know not all of you might have residents at your facility, but we're interested to know how you orient your new residents to the MEDIC work and to the interventions. I think
we're working on getting them back up. Perfect.
I can go ahead and answer briefly on that. I know that Raj has met with, the leadership that runs the resident program, and they usually do some sort of presentation during resident orientation to the site. And I believe that they give out little cards and, the information for the chest x-ray guidelines and PCARN, and we're pediatric only, so that would be the extent of ours, but that's what we do at our site so far.
All righty. Any other questions, Megan?
Yeah, so you all spoke, some of you choose to blind your data when you send it out to your providers, and some of you send it out unblinded. It sounds like that may have been an evolution for some of you. So we're just curious about what informed the decision to send it out blinded or unblinded, or to change along the way. And maybe we could start with Kristen also, since you mentioned that switch.
I think in the beginning, it was new. We didn't want to put all of our providers on the spot. And then as time progressed and, you kind of reached like that plateau where you're a little bit halted in your improvement. So I think we thought, maybe unblinding the data a little bit, not giving specific numbers, but doing it in those color zone charts might be a way to kind of get, the providers to maybe mingle, talk a little bit about it. They see where others are performing, maybe some friendly competition.
Any of our other abstractors want to talk about maybe why they keep it blinded?
I think with Henry Ford, we started at first keeping it blinded, just so providers could get a good idea of where they stand. And then with continued education and reinforcement, give them some opportunity to, maybe room for improvement. We have talked about possibly in the future making it unblinded, but as of right now, we're still kind of debating it. So I'm not sure when, if at all, we'll go that route.
I think we're in the same position as Heather currently at St. Joe Ann Arbor. The culture isn't just right. It's not a common practice for us today to share all of our information unblinded. And so as people are more comfortable with the information, I think, eventually we'll get to that point as well to unblind it.
Our site, we didn't feel like by leaving it blinded that we were really able to make a good impact, because then people could just think that that's not referring to me. That must be somebody else. That's the outlier that's bringing those numbers down. Haven't had a lot of negative feedback. I haven't. Dr. Slya might have, from our providers on making it unblinded. The previous manager that we had down here in the ER was a big fan of unblinding it for everybody. So even for our nurses, their patient satisfaction scores are posted in the break room board. So we tend to keep everything pretty transparent here.
Great.
Wonderful.
Awesome. We have another question here. So a couple of you mentioned separating out resident and PPA, APP data. And the question is, they're wondering if the feedback is being given to those individuals in addition to the physicians. So do they get their individual performance as well as what the physician performance is?
On my scorecard, I do break it out and put the mid-levels have their own column in there also, so that they're able to see how they did on all the head injury cohorts as well as the chest x-ray.
Our mid-level providers are also included on our color zone charts and in all of our reporting as well. We don't report at the resident level, but our mid-levels are included with the attendings and the providers.
Right, and ours also are all individually reported, and we reach out to clinicians individually. It's, again, the information isn't going to everybody at once. We're giving departmental trend information to everybody, but we're not sharing, for example, the graph that I showed, the pivot table graph, with all clinicians at once, again, because it's unblinded. So.
And at Henry Ford, we just send out data with only the ED providers. We have not tracked the mid-level providers or residents. That is something that I know we've been in touch with MEDIC trying to get that so it could be automatically pulled for us.
We are getting
right.
Fantastic. And one additional question here. So just a comment that all of these graphs and scorecards look fantastic, and wondering if any of you have a background or training in graphic design.
Nope. It's just all practice, seeing what I can do.
This was a very time-consuming process to start with. It's just trying to learn how to maneuver around with the data, how to display it to make it look appealing, how to put it, filtering data in and out. So it didn't happen overnight. It was a long process to finally get to where we are.
I think, Heather, that's a really good point. And I know you guys have been around close to since the beginning. And I'm just wondering if you guys have any advice for abstractors who are just starting out, or anybody who feels like they're stuck in their QI work. Kind of what would you tell them to kind of get them back on track and get them excited about their QI work again?
Well, I have to say that I think it's really encouraging when you start to see trends for improvement. The first year, it really, as I sort of outlined in my presentation, the first year is a lot of learning for an abstractor. And thankfully, we're not pressed to have those improvement goals, so to speak, at that time. We're not really into doing improvement projects. But, there's a lot to take in and a lot to learn. And you're starting to feel what information you get back from MEDIC when you go into the reporting, and now Tableau reporting. What is it? How can I manipulate, or what can I do with this data to make it relevant to the clinician, my champion? First of all, I feel like I work very closely with my champion so that he has the tools he needs to continue to do the good work at emergency department meetings and talk to clinicians. That's my
Wonderful. Yeah, that's great.
I think I agree with Nancy. When you start to see change, it's a good thing. I know with my data, me and my clinical champions, we work very close together. We're a great team. I always try to display the data so it's appealing, or even if I have to, do my own calculations for like CT head utilization, just to make it look like, hey, we are making change and it's working in our favor. And so.
Mm-hmm.
I think that is also, as an abstractor, like especially for newer sites, it's important to reference all of the information that MEDIC provides us in terms of the flow charts. Like you really have to understand how things are falling into each measure. That definitely helped me. I know in the beginning, I spent a lot of time, referencing those, learning the measures, learning, how the CPT codes pulled in, how the ICD-10 codes pulled in, and just playing around. And I mean, at the time it was Arbormetrics for us, but just playing around in the reporting database, it allowed me to see what was available, what I could pull, what I might be able to suggest become available in the future. I think that it's definitely a learning curve in the beginning, but it's so worth it once you start to see the numbers change.
And I found that by just taking notes of some of the things that I've been seeing as I'm pulling it from the cases, like seeing that I'm starting to have providers document their own age-adjusted D-dimer, prompted me to think, I should probably do something about that. Also, with all of those positive D-dimers coming in from urgent care, I felt I had to do something because I felt like our numbers were going to be going crazy, and it was not the fault of our providers at all because they weren't making this decision. And so that simple meeting that we had made a huge deal. And PE isn't even something that we're working on. So we did the pediatric chest x-ray. So I'm just doing this to help our providers and I guess help our patients out.
Well, thank you guys so much. Not just to you guys, for all of our abstractors for the work that you do, and you for in particular for taking the time to present today and have this discussion, and everything that you've said has been so valuable. And we hope that somebody out there in the audience today can take something that you've said and kind of implement it at their site next. So I think up next,